The title of my talk is Build Back Fairer. I chose that title for a report that I did in England, published in December of 2020, thinking the pandemic will be over soon. I used the same title for a commission that I led in the Eastern Mediterranean region of the World Health Organization. And then on the 30th of June, we published a report, Build Back Fairer, in Greater Manchester. So it has global as well as national significance. I want to talk today about work that we're doing at the local level in England. I could talk very happily about the Eastern Mediterranean region of WHO, but the reason I want to talk about the local level is that's where we appear to be getting traction. We've just started work in Cheshire and Merseyside. It includes the city of Liverpool, and it has 9 local authorities in it. 33%, a third of the residents, live in the most deprived 20% of neighbourhoods in England. 26% of children live in poverty. And the background to building back fairer after the pandemic was the report that I did and published in February 2020, Health Equity in England, the Marmot Review 10 years on. Just to go back, the Marmot Review was published in 2010, a strategic review of health inequalities in England, and we laid out what we felt needed to be done to reduce inequalities in health in England, based on a review of the evidence and on the WHO Commission on Social Determinants of Health that I had chaired. In February 2020, just before the pandemic started, we looked at what had happened in the previous 10 years. And my simple summary was, we've lost a decade, and it shows. Life expectancy for women and for men had been increasing about 1 year every 4 years. This graph goes back to 1980. I could take it back to the beginning of the 20th century, and it was about 1 year every 4 years. And then in 2010, there was a break in the curve, and the rate of improvement in life expectancy slowed dramatically. There was a new government elected in 2010, a Conservative-led coalition government. And the government asked, surely you can't be suggesting it's anything we did that could have led to this slowdown. Well, we need to look at it. One possibility, they said, is maybe we've just reached peak life expectancy. It's got to slow down sometime. So we looked at that. This is life expectancy improvement between 2011 and 2017 in all these different countries. Estonia, Norway, Slovakia, Hungary, Denmark, all the way down. And there's the UK, third from the bottom. The improvement in life expectancy was slower in the UK than in any other rich country except Iceland and the United States. So no, we had not reached peak life expectancy. This was a slowdown more marked than elsewhere. And then there's the social gradient in health. If you classify people by where they live and classify where they live by degree of deprivation, what you see is a gradient. Sure, people in the most deprived 10% have shorter life expectancy than everyone else, but it's a gradient. The less the deprivation, the longer the life expectancy for men and for women. The gap between the least deprived 10% and the most deprived is 9.5 years for men, 7.7 years for women. And that gap got bigger over the decade. The gradient got steeper. The inequalities increased. And when we look by region, this is women, similar picture for men. For the least deprived 10%, life expectancy improved a bit in every region, and the regional differences were quite small. If you're rich, it doesn't much matter where you live. But if you're in the most deprived 10%, the regional differences are much bigger. Life expectancy for the poorest 10% in London went up. But in virtually every other region, life expectancy for the poorest 10% went down. So this is where we were before the pandemic. Life expectancy had stopped improving, inequalities in health were increasing, and life expectancy for the poorest people was going down. And my general approach is to say that the health of the society tells us a great deal about how well the society is meeting the needs of its members. And if health has stopped improving, it means society has stopped improving. If health inequalities are getting bigger, it means inequalities in society are getting bigger. If health for the poorest people is getting worse, it means social conditions for the poorest people is getting worse. And to show you that in more detail, London is the top graph and the northeast region, but the northwest would look very similar. So in the least deprived 10%, you can hardly see any difference between the northeast and London. And then the greater the deprivation, the greater the disadvantage of living in the northeast compared to London. Or put it this way, if you're in the northeast, the greater the disadvantage of being in a more deprived area. And look at London. The dotted line is 2010-12. The solid line is 2016-18. And life expectancy improved across the gradient. The slope is very similar, so the inequalities didn't get smaller. But in the northeast, the dotted line 2010-12, the solid line is the later period, and you can see it got worse for the poorest 10% and a little bit for the next 10%. As I said, we're now starting to work in Cheshire and Merseyside. And life expectancy, the red line, is the average for males in England. In the northwest region as a whole, life expectancy is lower than the England average. And out of the 9 local authorities, all but 2 have lower than the average for England. And if you look, the blue line is women, and all but 1, maybe 2, have lower life expectancy than the England average. So we're starting to work in a deprived region of the country. And if we look at life expectancy at birth by level of deprivation for these 9 areas, for males and for females, you can see that Cheshire West and Cheshire East, which are the least deprived, have the longest life expectancy. Liverpool, Knowsley, which are the most deprived, have the shortest life expectancy. The gradient is living even within this region. And healthy life expectancy, once again, is shorter than the English average. Notice the female advantage for healthy life expectancy nationally is much smaller, because although women live longer, they spend more of that life in ill health. And the gap in life expectancy, the difference between the most and least deprived decile in each local authority in Cheshire and Merseyside, you can see that in Wirral, St Helens, Sefton, the inequalities are bigger than the national average. So we're talking about a national average of 9.5-year gap between the most and the least deprived deciles. And in Wirral, the gap is 13 years. And for women, it's 10 years. So there are big differences between local authorities and big inequalities within local authorities. In my 2010 review, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, ensure that everybody in a rich country has at least the minimum income necessary for a healthy life, healthy and sustainable places and communities in which to live and work, and that includes housing, transport, and local environments, and taking a social determinants approach to prevention. And my 2010 Marmot review was called Fair Society, Healthy Lives. What do I mean by a social determinants approach to prevention? These data come from the Food Foundation. If people in the bottom 10% of household income attempted to follow the healthy eating guidelines, they would have to spend 74% of household income on food. For those who are tempted to blame poor people for their poor diets, look at this. They can't afford to eat healthily. It's not ignorance. It's not laziness. It's not lack of knowledge of how to cook. Don't blame poor people. Blame their poverty. So what happened? 2010, the Conservative-led coalition government had as its principal mission to reduce public spending, and it did it. In 2009-10, public sector expenditure was 42% of GDP. And over the decade, that went down year on year. So by 2019, that 42% had become 35%. In my 2010 report, I coined the rather awkward term, proportionate universalism. And by that, I mean, we somehow need to combine dealing with the whole gradient and dealing with the worst off. So if the bottom line, for example, represents the gradient in life expectancy by some measure of deprivation or socioeconomic position, what we want is to level up. Have you heard that phrase? The Prime Minister in Britain claims he wants to level up. Well, to do that, we claim you need universalist programs with effort proportionate to need. The greater the need, the greater the effort. Proportionate universalism. What did we see? This is spending by local government. To the right, as you look at it, we've got the least deprived 20% of areas, and the grey bar represents total local authority spending per person. And in the least deprived 20% of areas, that spending per person went down by 16%. And then the greater the deprivation, the greater the reduction. So in the most deprived 20%, the spending went down by 32% per person. Remember, proportionate universalism said universalist programs with effort proportionate to need. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could this have contributed to worsening health and increased inequalities? Yeah, I think that's plausible. I won't go through all my recommendations, but one example, give every child the best start in life. One way of doing that is to eliminate child poverty, or at least to reduce it. Child poverty before housing costs, the bottom line, in 2010-11 was 18%. And child poverty is defined as living in a house at less than 60% median income. After housing costs, child poverty was 27%. And over the decade, that 27% became 30%. Increased child poverty. And this is one of the ways it came about. This is the change in net household incomes due to tax and benefit reforms by income and by household type. So the red is working age households with children. So in the poorest income decile, as a result of changes to tax and benefits from 2010 on, the poorest 10% will lose 20% of their income. The next 10% will lose 12% of their income. And then the higher their income, the less the loss, till you get up to about the 8th decile. And then there is some small loss for the top 2 deciles. It really looks like the government had a policy of making poor people poorer. A remarkably effective policy, neatly regressive. And coming back to Cheshire and Merseyside and the Northwest, this is average weekly earnings, age 16 plus. And you can see the England average is the blue line. The Northwest region is well below the blue line. And every one of the 9 local authorities except Cheshire East and Cheshire West and Chester have below average weekly earnings. Among the cuts to local government, there were cuts in services for young people. Could this be why there was a rise in crime? You can see there was a dip, and then violent crime went up, and it follows the social gradient. The more deprived the area, the higher the crime rates. It's plausibly related to the cut in services for young people and the worsening poverty. In Cheshire and Merseyside, the prevalence of obesity, I told you that there's a problem with lower incomes and greater deprivation. The dotted blue is the prevalence for England, and the prevalence of obesity in every one of these is higher than the England average. And the percent point change over that 1 year period was heading in the wrong direction. As I said in introducing this, in December 2020, we published Build Back Fair at the COVID-19 Marmot Review. I waited 10 years after the initial review to publish 10 years on. I waited 10 months to publish the COVID-19 Marmot Review because of the impact of the pandemic in exposing the underlying inequalities in society and amplifying them. I showed you before the social gradient in life expectancy. This is the social gradient in mortality, which in a sense goes the other way. And the dark green is all cause. You can see the social gradient. And the lighter green is COVID-19. And the gradients are almost exactly parallel. And what that means is the inequalities in COVID-19 have the same set of causes as the inequalities in health more generally. There's some relative excess in the bottom 3 deciles for COVID-19, which we think relates to employment in frontline occupations and living in overcrowded households. But in general, you want to deal with the inequalities in COVID-19, deal with the causes of inequalities in health. And then, of course, there's the ethnic differences. This is a comparison with whites. And the astonishing high mortality from COVID-19 among Black African, Bangladeshi, Black Caribbean, and Pakistani in England, and to a lesser extent, Indian. And what you can see here is the second bar of each cluster is adjusting for geography, which is linked to deprivation. The third bar is adjusting for other socioeconomic characteristics. And most of the excess, more than half, can be attributed to where people live and socioeconomic characteristics. Interestingly, for Black African and Black Caribbean, prior health conditions, the bottom of the 4 bars, doesn't seem to make much contribution. It does in Bangladeshi and Pakistani. I was on the BBC when these data came out, and a health minister said he was very concerned and people should wash their hands and practice social distancing. And I was asked, what did I think? And I said, good advice. And we need to deal with structural racism. And the excess mortality is very high in the UK. That's not looking only at COVID-19, but mortality from all causes. And in the early period to summer of 2020, the excess mortality in the UK was higher than in any other country. As the pandemic's gone on, you can see that, and we had higher excess mortality than even the United States, which was a disaster area when it came to managing the pandemic. As it's gone on, the US is higher than us and Spain, but we're still right up there with excess mortality. In other words, we've handled the pandemic very poorly. The Health Foundation published this looking at improvement in life expectancy 2010 to 19 and excess mortality in 2020. And what you can see is this negative correlation. The worse the health improvement up to the time of the pandemic, the worse did countries do during the pandemic. What's going on? Pre-pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown was nearly the slowest of all rich countries. And then in the first part of the pandemic, we had the highest excess mortality. And I think the link could work at 4 levels: poor governance and political culture, social and economic inequalities increasing, reduction in spending on public services. We were ill prepared, and we weren't very healthy coming into the pandemic, which would increase the risk. And COVID-19 mortality is higher in Cheshire and Merseyside and the Northwest than it is in England as a whole. Not surprisingly, perhaps, because those areas are more deprived. And looking at the particular areas around the country, West Midlands, Greater London, Greater Manchester, Merseyside, South Yorkshire, all of these large metropolitan areas have higher mortality than the English average. And in Cheshire and Merseyside, the same kind of gradient I showed you nationally. The less the deprivation, the lower the mortality from COVID-19, a remarkable social gradient. And at the end of June 2020, we published our report on Build Back Fairer in Greater Manchester, Health Equity and Dignified Lives. How would we apply our national report to one region, city region, Greater Manchester? The life expectancy decline in the Northwest in 2020 went down. Life expectancy went down by 1.6 years for men, 1.2 years for women, which it went down in England because we managed the pandemic so badly, but bigger in the Northwest. The Guardian newspaper had this front page. I sent it to a friend of mine in Washington, D.C., and he said both of those stories were jaw-dropping. England 2, Germany 0, jaw-dropping, and Michael Marmot saying that the fall in life expectancy in poor areas was jaw-dropping. We have a framework for building back fairer based on 6 spokes, and then in turn, 6 important areas. And the 6 spokes: build back fairer for future generations, build back fairer resources, standards for healthy living, institutions, the whole idea of anchor institutions, social value contracting, monitoring and accountability, and greater local power and control. If you look at public health, organized public health, the allocations for these cities were not so bad for the poorer ones. But public health spending reduction in real terms has been dramatic across the country. So when you think that the spending per person, the English average was around £60 per person, and got reduced by around £13, wow. What if we not reduced the spending in organised public health and given public health the task of test, trace and isolate? Perhaps we might have managed the pandemic better. And I said that monitoring is important, and we proposed 24 beacon indicators in each of our important domains of action. And working locally has a negative reason for working locally and a positive reason. The negative reason is if the national government isn't taking this seriously, then if we're going to work, we've got to work with local and city governments. The positive reason is that's where people live and work. That's where people are born, grow, live, work, and age. That's where the social determinants of health operate. We're also asking, what can health and care systems do, integrated care systems do, to approach social determinants of health and health equity. And when I spent a year as president of the World Medical Association, we produced a report on what doctors could do for health equity. But I think we can generalize that to what integrated care systems can do. Workforce, education and training, working with individuals and communities, seeing them in the broader perspective. We said health sector as employers, but I'd go further now and talk about anchor institutions, not just as employers, but the impact on the local community, working in partnership, and being advocates. When I chaired the Commission on Equity and Health Inequalities in the Americas for the Pan American Health Organization, I went for a wander in the mall in Washington, D.C., and came across this quote from Martin Luther King. I believe that unarmed truth and unconditional love will have the final word in reality. This is why right, temporarily defeated, is stronger than evil triumphant. Looking at what's going on in national politics in many countries is not a wonderful experience. But guided by Martin Luther King, I think we should believe that unarmed truth and unconditional love will have the final word in reality. This is why right, temporarily defeated, is stronger than evil triumphant. Thank you.